my name is Martina Porter. I'm a dermatologist at Beth Israel Deaconess Medical Center in Boston, one of the Harvard Medical School affiliated hospitals. And I'm also, as I said, a dermatologist, but I specialize in HS care and clinical trials. And I'm our vice chair of research and academics as well for our Department of Dermatology. This was the STOP-HS1 and STOP-HS2 trials were for moderate to severe patients with hidradenitis suppurativa who took a medication called Povorcitinib, which is Incyte's selective JAK1 inhibitor, and it's an oral medication. They actually looked at two different doses, 45 milligrams and 75 milligrams, and the primary endpoint was HiSCR 50 at week 12. But the trial actually went out to 54 weeks. And so after week 12, all the patients either stayed on the 45 milligram dose or the 75 milligram dose, or if they were on placebo, they were switched to one of those two doses, which was already pre-selected. And this is actually very similarly designed to other clinical trials, but probably one of the most significant differences is that in this study, patients were not allowed to take continuous antibiotics, which is what we've allowed in some of our other HS trials. And as we kind of find out over time is essentially more patients, because we have more medications approved, are exposed to other biologic therapies. And so this study actually had quite a high number of patients who had already tried other biologics like TNF alpha inhibitors and IL-17 inhibitors before they entered the trials. Whereas if we look back to the earliest stages of the adalimumab trials, which were Pioneer 1 and 2, all those patients were biologic naive. And this matters probably a little bit because of we think of the patients who have taken biologics as usually being more severe in disease severity and more treatment refractory too. So the population overall could be slightly more severe. But the very good news is that at week 12, which was the primary endpoint, about 40% of patients in both the 45 and 75 milligram groups achieved HiSCR 50 compared to just under 30% in placebo. And so this was a statistically significant result for both STOP-HS1 and STOP-HS2. And I think that means that we should see this drug get FDA approved and also get approved in Europe in the coming year, hopefully, maybe a little bit longer. But it'll allow us to have a totally different mechanism of action in an oral medication to use for HS, which is something we really don't have now. I think the answer overall is yes, with a lot of sort of this, that to go along with it. But I would say that the most important thing for patients is that when they start taking a medication, they notice that something is improving relatively soon. And I think it keeps them motivated to stay on therapy. And so seeing patients hit HiSCR 50 as early as week 3 is something that matters to patients. I always say in clinical practice that I think HiSCR 75 or approximately a 75% improvement is what allows patients to take a therapy and say they're happy enough and want to continue on. And this has actually been supported with some of our patient-reported outcomes where we really see pretty stark differences between patients who get 75% better and those who do not. So I think that's what I personally try to shoot for in clinical practice, but obviously the best outcomes for patients would be HiSCR 90 and HiSCR 100. But when you look across all medications and all trials, it's very hard to hit these HiSCR 75, HiSCR 90, HiSCR 100 marks. It's not like psoriasis drugs where we get PASI 75, PASI 90, PASI 100 in more than half the patients in less than 4 months. So even though we're looking at HiSCR 50 as our primary endpoint at week 12, most medications for HS, because this is such an inflammatory and long-standing chronic disease, we see even more patients hit HiSCR 50 at the 6-month or the 24-week mark, and then again at the 54-week mark. And I always tell patients and other people treating HS that this really, I think, is more of a marathon than a sprint for patients. And it requires a lot of patience on all of our parts, the patients and us, to really wait to see some of these improvements. And so seeing improvements at week 3 and week 12 are really important, but the maximum efficacy for most of these drugs really lies 24 weeks to 54 weeks down the line. And some of the long-term data from other trials now that have published 3-year data show that patients can even still have more improvements out to the 2 and 3-year marks. And I think For milder patients, we'll see improvements much sooner, but for patients who are Hurley 3 with long-standing disease, it takes a lot more time for them to get better, and so we don't want to give up too soon.